Welcome and thank you for joining us for today's webinar, Is This a Bipolar Illness? My name is Sydney and I'm from the PHN education team. I'm joined tonight by a lovely group. We have Dr. Ranasinghe, Olivia Gregg, and Erica Drew. Before we begin, I'd like to acknowledge the traditional custodians of the land that we're all meeting on tonight. For myself on the Central Coast, that is Darkinjun land, and I'd also like to pay respect to elders past, present, and emerging. Now, a few things to let you know about the session. It will be recorded and available for you to view in our education library in a few days' time, as well as a copy of the PowerPoint presentations from today. As attendees, your camera and microphone are automatically disabled. However, if you have any questions throughout the presentation, please pop these in the question box, which you will find located at the top of the control panel. We will answer these at the end of the session. Now, an evaluation will also come to you after the session. We encourage you to please fill this out because it enables us to put on future education sessions just like the one tonight. You will also receive 1 hour with RACGP tonight for educational activities that I will put through hopefully tomorrow for you, and that will go automatically in. Now I am going to hand over to Olivia Gregg.
Thank you, Sydney. Good evening, everyone. My name is Olivia Gregg. I'm a clinical nurse consultant and GP liaison with child and adolescent mental health services on the Central Coast with the Central Coast Local Health District. It is with great pleasure that I present tonight Dr. Ranasinghe. Dr. Ranasinghe is a psychiatrist and a consultant psychiatrist with CAMS, Child and Adolescent Mental Health, and also he is the clinical lead for the Young People's Psychosis Early Intervention Team. Dr. Rana is also a clinical director for mental health, drug and alcohol services with Brisbane Waters Private Hospital at Woy Woy on the Central Coast. His special interest is adolescent and youth mental health and addiction psychiatry. The topic of tonight is bipolar illness in adolescents. Why we have chosen this topic and Dr. Rana's kindly agreed to present is the number of recent referrals that we have been receiving as a service for a cohort of young persons between the age of 10 and 13 that are being referred to the child and adolescent services for diagnostic clarification of bipolar. So I will hand over kindly to Dr. Ranasinghe to clarify about diagnostic clarification and management of situations and young persons that come to our service. Thank you, Dr. Rana.
Thank you very much, Olivia. Thank you very much for your kind introduction. Again, thanks to Sydney and Erica also arranging this session today. As Olivia mentioned, is this a bipolar illness? We in CAMS team, Child and Adolescent Mental Health team, we get a lot of referrals saying that this child is having mood disturbances, emotional dysregulation. So whether this child is suffering from bipolar illness or not. Similarly, there are a lot of referrals we receive from various different organizations, clinicians, saying that this adolescent or youth or child having hears voices, hallucinations, so whether this is a psychosis. So because of that, we decided to present this topic today. So I'll go to my slides and then we will go through a few basic facts and then a case followed by a discussion. So as we mentioned, these are the learning outcomes and objectives. We would like to go through a little bit of prevalence rate in this age group and diagnostic techniques and case scenario, followed by challenges and difficulties, and then management options. I would like to mention that I got a lot of information from this document. This is College of Psychiatrists mood disorder guideline. There were two there were guideline before 2020 However, that was updated in 2020. Unfortunately, there are no significant amount of information regarding child and adolescent age group. However, there were some information, so I just absorbed those information into the presentation, so we can go through a few of the information they mentioned. Uh, this is nothing to do with child and adolescent mental health. This is basic facts about bipolar illness. As you all know, affective disorders comprise with major depressive disorder, then mania, sometimes specific one episode of mania, sometimes bipolar disorder, and then various other affective disorders. When it comes to bipolar illness, we need major depressive disorder by plus mania. Sometimes we see one episode of mania. We consider that as a part of bipolar illness as well. So typical bipolar illness, one episode of mania plus one episode of major depressive episodes. So that's how we diagnosed. But occasional one episode of mania can be taken as a bipolar illness. When we go to symptoms groups, there are a lot of symptoms. The one side, top of the slide, you can see more manic and irritability related hypomanic symptoms. The bottom part of the slide, you can see more depressive mixed type of symptoms. If I can summarize some of the symptoms, especially in mania, bottom part of the slide, inflated self-esteem, grandiosity, distractibility, pressure of speech, psychomotor agitation, increased goal-directed activities, lack of sleep, increased energy. All these things are highly suggestive of a manic episode. If those symptoms are not very severe, you can categorize that as hypomanic symptoms. Uh, Again, flight of ideas, elevated mood are symptoms of mania. Most of us, it's a, the, the depressive symptoms we can easily recognize: low mood, anhedonia, sleep disturbance, and so forth. When I'm presenting this slide, I have to mention some of the patients present with mixed symptoms. They have some depressive symptoms, at the same time some manic symptoms. Say they have suicidal thoughts, at the same time they have some psychomotor agitation or distractibility, or sometimes inflated self-esteem or pressure of speech. So there are mixed symptoms as well. So we have to take the episode as manic, hypomanic, depressive, or mixed. So all these episodes are helpful us to make the diagnosis or final diagnosis. Again, this is just basic facts according to the guideline. Depression is a common presentation. 12-month prevalent rate of major depressive disorder is 6%. So lifetime risk of depression is around 10 to 15%. So it's quite significant and prevalent than bipolar illness. Generally, male to female ratio of depression, major depression, 2 to 1. When it comes to bipolar illness, lifetime prevalence of bipolar illness is 1%. If we have 100 people, there is a one person can be diagnosed with the bipolar illness. Again, mixed bipolar illnesses they mention as there is an increase, the prevalence is increased up to 2.5. Male to female ratio is generally 1 to 1. When it comes to child and adolescent age, we can see mean age of onset is late teens. So bipolar illness can occur in late teens commonly, but the mean age of diagnosis is late 20s. So that shows that the disorder occurs uh, in 19 or 20 or late teens age, but diagnosis can be delayed due to lack of presentation to the clinicians or not taking it seriously. The diagnosis can be late. So that's a common phenomena. So when I was looking for information regarding adolescents and children, major depressive disorders are uncommon in children. So I will go to a definition of definition of children and adolescent in a minute. So major depressive disorders are uncommon in children. Incidence of major depressive disorder rises from mid-adolescent. So even though it's uncommon below 12, it can increase with the age. Predominant symptoms of childhood, the depression may be irritability and depressed mood. Melancholic features generally not common in children, especially in depression. Period of normality can be seen. If child is depressed, there may be some normality. They can play with friends in the school, they are okay, but when they come home they are more depressed and showing the symptoms of depression. So because of the age groups, I thought of getting some definition. So according to WHO, ages between 10 and 19 is considered as adolescent. This range falls, this group is called young people. And sometimes young people age group we mention from 10 to 24. Because of that, in my team, early psychosis intervention team manages clients up to the age of 24. So we accept clients from around 10 up to 24 with early psychosis. And in many societies, puberty is the age to define the adolescence age group. Before puberty, child and above puberty, or at that age, above that age, is considered as adolescent time period. uh, so bipolar disorders in adolescent and children. Early onset bipolar disorders can occur in young adolescent but are rare in children. So as we mentioned, depression as well as bipolar illness are rare in children before the age of 12. There is a term called pediatric bipolar disorder. This is an unofficial term. Described young people with classic episodic and severe mood disturbances. Their mood is up and down. They are having happy mood sometimes angry mood, or tearfulness. But this pediatric bipolar disorder confusingly has been applied to children with persistent and severe hyperactivity plus impulsivity and affective dysregulation. So if child is very impulsive, if child is having ADHD like symptoms, or if child is having oppositional defiant disorder, some people can use the term pediatric bipolar disorder. So it it's not a pure disorder, but it's given for various different symptoms categories. So that's why if a child or adolescent teenager presenting with mood disturbances, we have to be curious, what is this diagnosis? Is this a bipolar illness? Is this something else, like um, is this a trauma related issue, or is this a disorder of neurodevelopmental such as ADHD? So we'll go through the information a little bit and see what are the things we can get. I would like to present a case summary to discuss how difficult is to diagnose bipolar illness in this age group. So this child was referred to my team, early intervention psychosis team. Reason was that she was diagnosed with psychosis plus bipolar illness at the age of 13 or around 14. So this is a 13-year-old girl who is living in Central Coast. She is now 19 or 20, I guess. So we'll go through the case summary and then see what's the progression. She was first diagnosed, first admitted to a pediatric unit in 2018. That's 6 years ago. She was a high achieving student and she has a South Asian background. Parents both are working. So reason for the admission was she has a history of giggling, disorganization, aggressive behavior. So there was a mention that she was bullied in the school, and there were some family disagreement and discords also at the time. So as she was presenting with giggling, disorganization, aggressive behavior, quite correctly by the pediatric team, they have done full organic screening. The blood test and other tests all came negative. So at the time, psychiatric opinion was taken. The psychiatrist or a registrar has seen the child and adjustment disorder was diagnosed. During that short admission she was admitted to pediatric ward and then transferred to CAMS mental health team, CAMS mental health ward for 6 days admission. And brief psychotic episode was brief psychotic symptoms were noted, and they thought that she's having some psychotic symptoms in the context of stress. High stress resulting psychosis, which is not uncommon, or brief psychosis, not uncommon. So started risperidone, lower dose 0.5 milligram, and discharged to CAMS follow-up. So she was 13 at the time. So that's 2018. And within week of discharge, she deteriorated and this time presented to ED with abnormal behavior, again, disorganization, talking a lot. Talking a lot is a common phenomena in manic or hypomania, pressure of speech, we all know. And then psychotic phenomena noted. She showed some hallucination and suspiciousness. According to the note, she was paranoid. So then this time, previous time it was mentioned that psychosis in the context, brief psychosis in the context of stress. This time they saw that psychosis is relapse of psychosis they considered. So unfortunately, the child was in the hospital this time in Hornsby mental health unit. There's a CAMS mental health unit in Hornsby for 2 months. During the ward stay, staff noticed this child was singing loudly, she's irritable, she's angry, she's having mood changes, and she was crying, and they mentioned mood lability, and there was significant disorganization. She was unable to do any specific task, and she was very disorganized. So bipolar affective disorder was considered, and discharged. She was discharged on lithium and olanzapine. Can't forget the fact that she is still 13, and bipolar disorder generally do not, it's not common in this age group. It's a very rare presentation. But she, this is the second admission over the last few months, and last admission was 2 months in the hospital. So she was properly observed by the nursing staff, psychologists, social workers, psychiatrists, and registrars. In the end, they diagnosed her with bipolar illness or bipolar affective disorder, and um, discharged on lithium and olanzapine. So she is 13. So CAM's follow-up was continued, and she was fine for few months or less than a year. Another episode at the age of 14. So this time she was admitted again to CAM's mental health unit in Hornsby. 3 months admission. You can say the first episode, first presentation, few weeks, 6 days, and then 2 months, and this is 3 months. So this time, following observation, she was diagnosed with bipolar affective disorder 1. Bipolar affective disorder 1, bipolar 1 disorder was diagnosed, and this time uh, medication were changed to, she was on olanzapine already. That was continued, and sodium valproate was started. And she came to my team, early intervention team, where she was with us for 4 years. As she was having a second or third episode around 14, and she was with us 4 years. During this time, she was able to complete HSC and few courses and enrolled in university as an OT student. So I have to say that over that 4 years, I managed her at least 2 years. She was reasonably stable. Our main focus was her education, and she was on a lot of medication, but she was able to avoid hospital admissions and finish HSC. Can't forget the fact that there were high expectation from her side as well as from family side. So in one or two occasion, this kid was very friendly and very polite child. She was disappointed that she was not able to reach her maximum potential because of mental health issues. However, she completed HSC and entered into uni. So then I haven't heard much about her for maybe 2 years or 18 months. And then recently I saw, I got a referral from one of the GP to my private practice. Then I saw there was some information in the EMR, the the information system, that she had multiple admissions and multiple ED presentation recently. That's in 2023 and 24, and she was admitted to adult mental health unit in Gosford Hospital with significant emotional dysregulation, coping difficulties, suicidal thoughts, pardon me, suicidal thoughts, and depressive symptoms. So during those admissions to adult mental health unit, she was diagnosed with borderline personality disorder. Now she is being discharged on very low dose of valproate, olanzapine, and aripiprazole. Uh, and managed by the community mental health team. So, what is the diagnosis? That's a question. At the age of 13, she was diagnosed with bipolar illness. At the age of 19, she is re-diagnosed with borderline personality disorder. So I'm questioning whether this is a bipolar illness. She had very clear episodes in 13 and 14, 2 and 3 months admission. She had psychotic symptoms. She had manic behaviors. Uh, and she was observed by psychiatrists, registrars, nursing staff, multidisciplinary team. And their view was this is bipolar illness. She was manic. It could be true. Could it be borderline personality disorder? Whether she had those symptoms at that age, is that possible? Maybe, but if someone has a history of episode for 2 months or 3 months, it's very unlikely to be a trauma related or personality because they are in our care. We observe them all the time. So it, there is a possibility of borderline. Could it be both? Again, another possibility, because when she had the episode at the age of 13 and 14, she was highly medicated. She was treated with olanzapine, valproate, lithium, and multiple medications, and then discharged on those medications. Perhaps bipolar part of the illness might have been controlled by the medication, now presenting with borderline personality symptoms. So she may have both, but so that's the difficulty of difficulty of diagnosis of bipolar illness at this stage. So if someone is presenting with a manic or hypomanic or depressive episode or behavioral disturbances, there are few differential diagnoses we can consider, especially in this age group, children and adolescents. There is a condition according to DSM-5 classification called disruptive mood regulation disorder. So these kids are always angry, irritable, they are not happy. Always, it's a minor matter can cause significant anger and irritability. So those those kids, we can diagnose we can diagnose mood dysregulation disorder. So the kids with disruptive mood dysregulation disorder can progress into major depressive disorder very commonly than not. So that's a predisposing factor for major depressive disorder. Complex trauma and related presentation, obviously very common with complex trauma, complex PTSD or similar presentation. Mood disturbances are very common: happy, high, low, anxious, angry. All the moods can be seen in a shorter period of time. Self-harm behaviors are common in these kids: cutting, overdosing, that type of things. And impulsivity again, so they don't have control of their impulses. Anxiety and depressive symptoms, feeling of psychotic phenomena or fleeting psychotic phenomena are common in trauma-related trauma-related cases. So I have avoided BPD at this stage because we need symptoms, all the symptoms, we need to wait till they are reaching late teens to diagnose. But we can see BPD symptoms, borderline personality symptoms in teenagers, though we are not much diagnosis, not diagnosing at this stage. So other differential diagnosis, this is my subspecialty, substance use disorder, mood changes, psychotic symptoms, altered behavior, common. If someone is presenting with uh, substances like methamphetamine, if the child or adolescent, the teenager taking methamphetamine in a uh, weekly or fortnightly basis, they can become uh, they can become psychotic. They can show mood changes. They can show impulsivity. So someone can diagnose substance use disorder as bipolar illness. Common due to peer pressure and risk-taking behavior in this age group, and uh, the common issue is the substances like methamphetamine and highly potent THC contained in cannabis freely available in the market or black market or even in the schools. So we can't forget that the risk of developing substance use disorder and coming with manic, hypomanic or psychotic presentation. My team again, young people early intervention team manages children up to 24 with first episode psychosis or psychotic phenomena. As we had the differential diagnosis of borderline personality disorder, which is a common presentation in late teens with pervasive patterns of interpersonal relationship issues, self-image difficulties, affect disturbances, and marked impulsivity. Pardon me. So there are a number of criteria, 9 criteria. We all know, like fear of abandonment, self-harm behaviors, mood dysregulation, uh, rapid mood swings, impulsivity, anger issues, recurrent suicidal thoughts, behaviors, threats, chronic feeling of emptiness, and uh, transient psychotic symptoms. Transient and stress related psychotic symptoms are features of borderline personality disorder. If we apply this to the case we discussed, TN, you can remember when she was at the age presenting first time at the age of 13, they mentioned that stress related psychotic symptoms, that's one of the symptoms of borderline personality disorder. I'm not saying that she had borderline, but she had stress related psychotic symptoms at that age. Bipolar 2 disorder, as we know, the bipolar affective disorders are various different categories. One is bipolar 1 disorder. To diagnose bipolar 1 disorder, client should have at least one manic episode. Bipolar 2 disorders, clients are predominantly depressed. They have occasional hypomanic episodes. So if they have reached little bit hypomanic symptoms with more depressive symptoms, it's a bipolar 2 disorder. Another differential diagnosis is ADHD and other neurodevelopmental disorders. Kids with ADHD having rapid speech, they are impulsive, they have racing thoughts, they are distractible. With ADHD, some kids have less sleep than normal, so less need for sleep. So all these symptoms like rapid speech, racing thoughts, distractibility, poor sleep are symptoms of hypomania or mania as well. So the how to differentiate this is not difficult. Kids with ADHD having symptoms from very early childhood, like age 3, 4, 5, 6, from that age and going to continue till teenage years and even to adulthood. So we can differentiate ADHD from bipolar illness or manic episode. So I thought of presenting this slide. I got this from Australian BPD Foundation Limited website because we commonly hear the word complex PTSD and borderline personality disorder. We all know the PTSD is related to significant threat or trauma to a person and develop anxiety, re-experiencing of the trauma-related symptoms, and avoidance. So threats or trauma plus avoidance plus re-experiencing of symptoms and anxiety is necessary to diagnose PTSD with a significant functional impairment. On the other side, green side, BPD, borderline personality disorder, as we discussed, fear of abandonment, mood swings, anger issues, recurrent suicidal thoughts or behaviors, dissociative symptoms, identity disturbances, affective instability. All these things are part of borderline personality disorder. And when it comes to complex PTSD, especially in children and adolescents, they are presenting with very severe, significant childhood trauma. Most of the children presenting with complex trauma, not only one type of trauma like physical trauma, they are presenting with physical, sexual, emotional trauma, a lot of neglect. So those kids can develop complex PTSD with more PTSD symptoms plus mainly the affective instability and negative self-concept or uh, unstable affect, that type of symptoms. Fear of abandonment is not much prominent in complex PTSD. Transient psychotic symptoms is not common in complex PTSD. Uh, Chronic emptiness is not common, so it's very difficult to differentiate, but there are little bit of the symptoms categories you can use to differentiate, but these kids may present with all three things, PTSD and then BPD and then mixture of both. So when it comes to formulate the case of bipolar or mood disorder, we need comprehensive assessment and especially the current symptoms, previous symptoms, uh, trauma history or developmental history, and then previous treatment, psychological treatment or medications and things like that. And then we have to clearly see the pattern of the illness. If someone is presenting with very episodic illness, teenagers who are having bipolar illness presenting with manic or depressive episode, in between episodes their level of function is normal or level of function is much better, and during the episode their functional level deteriorates, and we have to see whether there are any precipitating factors such as drug use, alcohol use, bullying, stress in the school and family life. So all these things need to be considered as a part of formulation, and we can't forget the fact that strong family history is attached to bipolar illness. So if there is a family history of mental illness or bipolar illness, the kids or teenagers have high tendency to develop bipolar illness. So we have to get the collateral history to check the genetic loading of bipolar illness or psychosis. So these are the level of care according to mood disorder guideline. if someone is presenting with a mood disorder, it's not specific to bipolar illness, I would say. It's any mood disorder, it's a depression or uh, mania or bipolar illness. So we have to assess their level of symptoms and initially just uh, provide the basic support, uh, sometimes supporting to improve some of the symptoms. And then second level is outpatient care with the help of the general practitioners. And then third level is symptoms are, if moderate to severe, specialist diagnosis or services like camps necessary. And then sometimes inpatient care is necessary. So there are various different levels. And primary care setting, we can use level 1 and level 2 to provide basic support, symptomatic treatment, psychological therapy, that type of things. So again, systems for children and adolescent, again, general advice, as I mentioned, can get help from the psychologist to do the assessment and support the child for school needs, that type of things. Level 2, we can go to camps, specialist assessment. Then level 3, multidisciplinary services like early intervention team. And then level 4 is very highly specialized mood disorder treatment programs. Again, the fundamentals, foundations of the treatment and the levels, lifestyle changes, exercise, healthy eating. Then we go to psychosocial intervention, psychological intervention, little bit of CBT, counseling, supportive psychotherapy, all helpful. If those things are not helpful, we go to next level, pharmacotherapy, for the depression, antidepressant treatment. And then bipolar illness, mood stabilizers, antipsychotic medication. And always we combine pharmacological treatment with psychological treatment. And then if conditions are very severe, cannot be controlled by medication, and if there is any high risk, other treatment options. Very rarely we use ECT, or I never used ECT for children or in adolescent age. So those are mainly for adult. So those are higher level treatment for these conditions. So this is my presentation regarding bipolar illness. And if there is any question you can ask. Again, thanks to Olivia, Sydney, and Erica. And last paragraph, I would like to mention to the GPs, if you are around, if you are hearing this presentation, there is a 24-hour GP advisory line, mental health support line for GPs. Any GP wanting advice regarding a patient, you can contact Gosford or Wyong Hospital Switch and can speak with on-call psychiatrist anytime. This service is 24/7. I am here in Central Coast around 8 years as a psychiatrist. I only got 2 phone calls over the 8 years. So this service is not being used adequately. So if any GP wanting to get a opinion regarding their client with mental health issues in front of you, give a call to this number or Wyong Gosford, speak with on-call psychiatrist, get advice. We are happy to provide advice and guide you to help the client with mental illness. My view is that this is not being used much. Thank you very much.
Brilliant. Thank you, Dr. Ranasinghe. Now, we have had a few questions come through that I will go through. Now, I am going to apologize in advance if I pronounce some of the names wrong. For me, they're a little bit tricky. Okay, the first question that came through, it said, why to antipsychotic? It says olanzapine and aripiprazole. That one's really hard. And that's the first part of the question, so I'll let you go on that one first.
Yeah, in TN's diagnosis now re-diagnosed as borderline personality disorder. My view is that she may have both diagnoses. She was recently discharged. Yes, she was discharged with olanzapine, aripiprazole, and sodium valproate low dose. My guess is that they have managed her in the ward with sedating olanzapine and started aripiprazole, maybe because of weight gain, to thinking about increasing aripiprazole and reducing and tapering of olanzapine. That's my guess. But this teenager, I am not managing. Because of my case, I went through the case note. So that's my view. So they are maybe trying to stop olanzapine because of the severe metabolic syndrome.
Okay. And then it says, why valproate, not lithium on women reproductive age?
Yeah, that's a question. So, uh, when she was presenting first time or second time, that's 6 7 years ago. So she was initially on lithium first presentation, but she had significant side effects to lithium. Then they, because she was in hospital for 3 months without significant improvement, they started valproate. I totally agree with that. The doctor who asked that question, why not lithium? Why not lamotrigine? In my practice, I now avoid uh, prescribing valproate even for the males. So I'm trying to avoid for any age groups, which is a very bad medication. Yeah.
The role of psychotherapy in this case?
Role of the psychotherapy, she was with early intervention team for 2 plus years. So during that period, she was case managed by a specific case manager. Unfortunately, there were changes during those 2 years. She received cognitive behavioral therapy, supportive psychotherapy, mainly those two, not the dialectical behavioral therapy, but she received ongoing therapy during uh, those 4 years. That may be one of the reason there was no admission during that period. So she had admission 13 14, 4 years no admission. At the age of 19, multiple admission. So the psychotherapy or psychological therapy part was stopped after we discharged her from our service. But recommendation was to continue psychological therapy through Headspace subsequently and through the private psychologist, but it didn't go very well.
Yeah. If BPD, why we don't stop all psychotropic med but psychotherapy?
BPD, obviously, recently I heard from expert that obviously there are no medication for borderline personality disorder. But unfortunately, when we see the patient is on antidepressant, antipsychotic medication, and mood stabilizers. All are with multiple medication. Why do we treat with these things? We are treating for their symptoms. So with the antidepressant for depression, mood stabilizers to control mood disturbances, mood fluctuations, and things like that. So always psychological therapy is the first preference, but when it is psychological therapy is not controlling symptoms, symptomatic treatment are used.
Perfect. What illicit drug did she use?
she never used drugs. She has no drug history, so that's a protective factor. And she had good reputation in the school, another good factor. High expectation in a way affecting her mental health side. Uh, and I have to say there's a family history of personality disorder also. That's forgot to mention. There was no drug use even up until this age. She's now 19 or 20. She no drug use.
Yep. Could it be substance-induced mood disorder?
Unlikely if she's not taking substance, because she presented at the age of 13, 14. I mean, when someone is presenting first time, second time to emergency department, very commonly we do urine drug screening with the patient is denying or not. It's a common phenomena, urine drug screening, but there was no history from her or family. So
Perfect.
but
Yeah, sorry.
it's a differential diagnosis for other clients.
Yep. Should sodium valproate be avoided in adolescent females slash due to risk of teratogenicity? What is your approach to prescribing sodium valproate in this cohort?
I mean, in the past, there was a situation we used that, not anymore. So it's, I mean, if I'm managing this client now, I would cease it and go for something else, maybe lamotrigine, lithium, more safe options.
How would you treat coexisting bipolar and ADHD? Can stimulants be used?
That's a tricky question. It's difficult because stimulants such as methylphenidate or Concerta or dexamphetamine or Vyvanse can precipitate manic episodes. uh, Recently I have a client. She is 19 years old. She was on Vyvanse 70 milligram for ADHD and mild intellectual disability. There was no other reason. She presented with severe manic episodes to Wyong Mental Health Unit, had 2 to 3 weeks admission and discharged on antipsychotic medication. So obviously that's a challenge, but uh, with the mood stabilizers for the bipolar illness, we can trial medication. There are second line medication like atomoxetine, guanfacine, there's Intuniv available in the market, so we can use those medications if there is high risk of developing or relapsing bipolar illness.
Can stress be the only trigger for borderline personality disorder?
So I missed that, sorry.
Sorry, I was excited that I could say the whole sentence. Can stress be the only trigger for borderline personality disorder?
uh, to develop borderline personality disorder or complex PTSD, there should have very severe trauma in the past. So that is one requirement. I mean, not a requirement, a trauma, and then to present with BPD stress. I would say don't think it's the cause for to develop BPD. By saying that, I have seen um, children and adolescents without any trauma with good family life developing BPD. So trauma is a predisposing factor, but without trauma they can present with BPD.
And last question at the moment for borderline personality disorders, the Central Coast LHD has suspended their DBT. Do you know if they will commence it as many patients cannot afford it privately?
Uh, this is the info. I knew that it was ceased, I think, during the COVID time or during that time, because patients were not able to attend the groups. And then Central Coast Health District contracted one of the private hospital to do DBT program as a pilot project. I'm not very sure whether it went okay or not. So it's not available at this stage. That's my understanding. And if someone has a private health insurance, there are private hospitals doing the group therapy program for BPD, dialectical behavioral therapy group programs.
Yeah. Would you say, in your professional opinion, that BPD is the hardest mental illness to treat?
BPD is a spectrum. It's like there are people with mild BPD symptoms. They are functioning okay. They are doing well. There are no major issues. But due to some stress, they can get worsening or precipitating symptoms. Moderate BPD, on the other hand, can be managed with good psychological therapy and symptomatic management. When it is come to severe borderline personality disorder plus other comorbidities, especially like drug and alcohol issues and uh, uh, the conditions associated with BPD like comorbidities, then it's difficult to manage. So need comprehensive multidisciplinary team management. Unfortunately, not available in most of the places.
Yeah. And just a comment that Headspace runs many DBT groups.
Sorry, I missed that again.
It was just a comment that Headspace, that they run many DBT groups.
I think there may be some program, but I don't know whether there are, I can't answer that yet, maybe.
Yeah, I might have Erica delve into that one at another time if we can dig into that, but that's good knowledge if it is. Another one, is it common for people with bipolar disorder to have frequent changes of medication?
I would say not common. There are situations, medications are changed mainly because of when someone is in inpatient unit with a manic episode, they like to control symptoms. But when patient comes to the community, our challenges are like if patient is getting olanzapine, for example, weight gain, metabolic syndrome, sedation, sleepiness, all these things are problems. So we have to change their medication to more metabolically uh, healthy medication. Uh, we sometimes change medication, but it's not a common phenomena. Yeah.
Perfect. Well, that is all the questions for today. So we will hand it over to Erica Drew from Health Pathways. And thank you for that, Dr. Ranasinghe. That was brilliant.
Thank you very much. So I'll just quickly run through the health pathways. So hopefully we've got people from both of our regions within our PHN. So we've got Central Coast Health Pathways and Hunter New England Health Pathways login details there for you and the QR codes for you to be able to access them. Specifically related to the topic of the education tonight, on the Central Coast, I've listed the relevant pathways there, and those are active hyperlinks. So if you look at the resources, the PowerPoint is pasted in there, and you can click directly to those hyperlinks. So there is a bipolar disorder pathway localized for the Central Coast, also acutely disturbed young person, self-harm pathways, and then anxiety, depression, and OCD and suicide prevention, specifically for children and young people. We've got the physical health and mental illness pathway, psychosis, and then suicidal ideation and intent, and suicide prevention referral page. And then we've got the mental health referral pages for child and youth specifically, and then also some general pages regarding all ages. And then I'll just pop over lastly to Hunter New England. So similarly, Hunter New England also has the bipolar, the self-harm pathway, psychosis, suicide ideation and intent. And then they've got those 3 specific child and youth mental health pathways. And then their section on the specialist mental health services is quite extensive as well. I just picked out that one there, psychiatry and specialist mental health services, but there are a lot more referral pages as well. There would be information about private options for DBT therapy, and also the public options for mental health in both regions. Thank you very much.
And big thank you as well to Olivia Gregg. I'm sure she's still there somewhere.
Yep.
Without you, we wouldn't be able to put these sessions on. You are the mastermind behind organizing all of them. So huge thank you from the PHN.
Thank you to you, Sydney, to Erica, but most so thank you to Dr. Ranasinghe. This is an amazing topic, Doctor. And because of my discussions with you during the time at CAMS, the frustration we experience as a service when we get these referrals and we're unable to support these young people because of resources and also because of the diagnostic clarification issues involved. But thank you very much, Dr. Ranasinghe. It's very much appreciated. Thank you.
Huge thank you, everyone. And we will see you next time.
Thank you, Sydney. Thank you,
Good
Erica.
night.
Good night, Dr. Rana.